So in the last video we talked about autonomic intervention when it came to the beta receptor. So we're going to talk about the other receptors when this one. So we're going to start by talking about the alpha receptors in the cardiovascular system and of course coronary arteries. So postsynaptic receptors can be alpha 1 and alpha 2. But sympathetic nerves cause coronary vasoconstriction because there is higher preponderance of alpha 2 over alpha 1. But there is alpha 1 receptors in the coronary arteries too, not just alpha 2. The larger epicardial arteries primarily have alpha 1 receptors. Small coronaries have more alpha 2 receptors. But epicardial vessels contribute only to about minimally to about 5% of the total resistance in the coronary circulation. So alpha 1 agonists like phenylephrine have little influence on the coronary resistance. Again, if you remember, the coronary resistance is primarily mediated by local effect. So this 5% is not significant. What about myocardium? Postsynaptic alpha 1 receptors result in a major positive inotropic effect. So they make increase the contractility. Phenylephrine and alpha agonists can increase myocardial contractility to 2 to 3 fold. And this is primarily from studies in vitro. But this 2 to 3 fold in vivo is not significant enough for us to call phenylephrine an inotrope. So when you compare it to isoprosternal causes 6 to 7 times increase in the contractility. The postsynaptic alpha 1 receptors in the myocardium mediate about 30 to 50% of the basal inotropic tone in a normal heart. What about peripheral vessels? When you activate presynaptic alpha 2, it results in vasodilation. Again, presynaptic alpha 2, when you activate it, you get vasodilation. When you activate the postsynaptic alpha 1 and alpha 2, you get vasoconstriction. This is because presynaptic alpha 2 receptors inhibit release of norepinephrine. This is a negative feedback to control. And the presynaptic alpha 2 agonists like clonidine inhibit norepinephrine release at the neurosympathetic junction, so that's how it results in vasodilation. But most sympathomimetics are not selective agonists, so they're non-selective. So they will equally stimulate the presynaptic alpha 2 vasodilating receptors as well as the vasoconstrictive postsynaptic alpha 1 and alpha 2 receptors. Postsynaptic alpha 1 and alpha 2 receptors are present in both arteries and veins. But the veins have much more alpha 2 receptors. So if you give a pure alpha 1 agonist, you get very little venoconstriction. But when you use a non-selective alpha agonist like phenylephrine, you get significant venoconstriction from the activation of alpha 2 on the veins. And in fact, norepinephrine is the most potent venoconstrictor of all the catecholamines. What about the central nervous system? All subtypes of the alpha, beta, and dopamine are present in different regions of brain and spinal cord. Brain and spinal cord presynaptic alpha 2 receptors are involved in the inhibition of presynaptic norepinephrine release, so not too dissimilar. Circulating catecholamines, though, they don't cross the blood-brain barrier. And many actions can result from the activation of cerebral postsynaptic alpha 2 receptors. It results in inhibition of insulin release, inhibition of bowel motility, stimulation of growth hormone, and also inhibition of ADH release. What about kidneys? The kidneys have an extensive an exclusive adrenergic intervention. So there is no cholinergic intervention to kidney, it's adrenergic. The greatest concentration of innervation is in the thick ascending loop of Henle. Both alpha 1 and alpha 2 are present there, but there is higher preponderance of alpha 2 receptors in the kidney. Now again, we're talking about the kidney itself. The alpha 1 receptors are more predominant in the renal vasculature, and when you activate them, they result in vasoconstriction. Now, tubular alpha 1 receptors enhance sodium and water reabsorption. So, when they get stimulated, you get less urine output. Tubular alpha 2 receptors promote water and sodium excretion, so the opposite effect. So again, the feedback control of urine output is in part controlled by this.